Welcome everyone to the session BSeR. Our speakers today are Tia Pope, Andy Stevens, and Myung Choi, and we are now going to get started.
Welcome everyone. Thanks for joining the session on Bidirectional Services eReferrals, also known as BSeR. I am Tia Pope, Director of Health Interoperability within the HEAT Division, or Health Emerging and Advanced Technologies, at Georgia Tech Research Institute. I'm joined by FIRE certified leaders, researchers, and innovators within my branch, Myung Choi and Andrew Stevens. In this talk, we'll cover an overview of BSeR, discuss the IG, share a little bit about our collaboration with YUSA and what we've learned from them. From there, we'll wrap up with our plans for building a proof of concept platform for bi- and multi-directional referrals, the challenges we've had and anticipate, as well as the next foreseeable steps. Feel free to drop your comments or questions in the chat as we go. And now we'll have Andy jump in and share about BSeR.
So what is BSeR? BSeR stands for Bidirectional Services eReferrals, which facilitate an information exchange between a referral initiating provider, for example, a primary care physician, and a referral recipient provider, for example, extra clinical programs for lifestyle management, like a weight management program or a diabetes management program that is not offered through the primary care physician's office. One of BSeR's core requirements is following the HIPAA minimum necessary standard, which means that HIPAA-covered entities are required to make reasonable efforts to ensure access to protected health information is limited to the minimum necessary information to accomplish the intended purpose of a particular disclosure. The closed-loop design shown at the bottom between the initiator and the recipient allows for constant provider engagement as well as constant reporting of patient outcomes. Why are bidirectional referrals important? Bidirectional referrals emphasize prevention and the role of healthcare outside the clinical setting. It allows for an increased number of touchpoints with patients, as well as reinforces positive behaviors from both the clinical and extraclinical sides of the referral. They also allow for improved care continuity for the patient by extending the care team beyond the clinical setting. Establishing a bidirectional referral pathway can be beneficial to healthcare providers and lifestyle change providers alike, and can ultimately enhance the patient experience and improve health outcomes. The BSeR implementation guide was created to start tackling bidirectional referrals in the FIRE ecosystem. It had its STU1 release in March of 2020 and has plans for an STU2 release in the future. The IG defines profiles to support 6 different use cases: obesity, arthritis, hypertension, early childhood nutrition, tobacco use cessation, and diabetes prevention. The IG also defines support for transfer of information with either FIRE messaging resources or via traditional REST operations such as GET and POST. One large challenge in this IG is that FIRE is not at a maturity level to capture every single use case for bidirectional referrals. This leads to predefined use cases with the ability to extend further to other use cases as needed. There are currently plans to continue iterating on it for an STU2 release in the future with use of FIRE shorthand, also known as FISH, more clinical and extraclinical partners, as well as Connectathon participation. This shows a screenshot of the homepage of the published BSeR STU1 IG currently available online. Crossover also exists between the ongoing Gravity project and BSeR, considering multi-directional referrals. Referrals can contribute to identifying social determinants of health, SDOH, as well as insights for reducing inequalities. The CDC has noticed this crossover and has been working with both groups to continue to define BSeR and support Gravity, as well as launching the Public Health Use Case Work Group for Chronic Disease Prevention, which builds off of some of the Gravity use cases. An example use case for BSeR is with an extraclinical partner, YUSA. YUSA, also commonly known as YMCA, is a nonprofit committed to strengthening community by improving the health and well-being of people of all ages. The specific BSeR use case can be found in their diabetes prevention program, which is a year-long program led by a trained coach with CDC-approved curriculum. In this example, there's going to be 2 different entities acting in this: the healthcare provider, referred to as the HCP, and the lifestyle change provider, referred to as the LCP. The healthcare provider will be the referral initiator, and the lifestyle change provider would be the referral recipient of this BSeR transaction. This shows the YUSA use case scenario for the diabetes prevention program. The patient visits the healthcare provider, is screened for prediabetes, and provides consent for referral. The healthcare provider refers to the lifestyle change provider via eReferral, which includes key health information. The lifestyle change provider contacts the patient, confirms qualification and interest, and enrolls the patient into the lifestyle change program. The lifestyle change provider provides electronic updates to the healthcare provider on patient progress once the program starts. The healthcare provider monitors patient's progress and reinforces this behavior change with the patient at their next clinical visit.
Thank you, Andy. Speaking of YUSA, I want to elaborate on a few of YUSA's top challenges and breakthroughs as it pertains to referrals. One of its top and largest challenges has been COVID-19, just like the rest of us. Right when they were starting to make progress towards testing referral tools and FHIR, the pandemic hit and the EMR and clinical teams were pulled towards public health emergency related activities, and rightfully so. Since then, it has taken the last solid 9 to 12 months for everyone to reset and begin to talk about implementation again. With that being said, it has taken a lot of patience and of course rework to pick back up the efforts. Fortunately, timing is now aligned with funding given the worldwide efforts for modernizing health and public health data flows. With any significant change in health or public health, we know that at some point you're going to hit reluctance, whether that's from systems or staff. YUSA has found that while BSeR standards provide the guideposts, specifically how the work is implemented is up to each partner's EMR and clinical teams. Some of the partners are more comfortable moving forward with ambiguosity more than others. To that effect, uptake has been slower than desired since YUSA doesn't currently have an off-the-shelf roadmap to accelerate the timeline to production. While their respective partners are interested in doing this work, their comfort with the approach has varied. Good news is that we've partnered with the CDC in collaboration with YUSA to provide a roadmap for community-based organizations, as well as respective clinical and public health collaborators. In addition to this, we intend to work with YUSA as well as other CBOs to help define needs from clinicians and IT staff, which will allow for more synergy and buy-in. YUSA has had a few early potential pilot partners indicate that they would not move forward with direct community-based organization referrals through BSeR or BSeR FHIR because they were already participating in third-party referral platforms and didn't see the value in creating direct to CBO referral pathways. Additionally, CBOs didn't see benefits for adding new workflows, which affected uptake. And even though the cost was free to the partners, the effort wasn't enough to drive adoption. Additionally, there were no clear paths for supporting CBOs who would need to integrate a new system into their own workflows. Generally, CBOs have limited resources and must prioritize activities that they see as having the greatest value and also the highest impact on their clients and patients. We are now working together to showcase the value for both providers and community-based organizations and hence eliminate major lifts that would encourage adoption. Fortunately and excitingly, partners are now eager to figure this out, even though implementation is not always clear or the roadmap hasn't been fully built out yet. They have been committed to remain in the project. So GTRI, we will be working with CDC, YUSA, and other community-based organizations to continue to fan the flames of desirability as well as ensure viability and feasibility. A collective and overall goal is to embed a standardized referral process within clinical workflows and to only exchange relevant data. We continue to hear this is needed and can set the stage for future referral pathways. This also enables the CBO side to facilitate feedback to the clinical referral partners at whatever intervals are determined. We will work with YUSA and other CBOs to reduce burdens and build strong feedback loops that benefit all parties, but especially the patients. The work with the BSeR IG team, connectathons, and interoperability showcases have demonstrated the WISE commitment to bridging the clinic to community gap and has opened up opportunities for meaningful partnerships between the WISE and their healthcare partners. We intend to leverage this foundation to help support CBOs across the nation. Speaking of which, I would like to have Myung share a bit about the YUSA's reference implementation architecture and how we plan to generalize the approach for broader use and FHIR adoption for information exchange.
Thank you, Tia. In the previous Connectathon, YMCA participated as a partner for service provider. In the YMCA BSeR architecture, service provider receives the eReferral from clinical provider using a FHIR message and processes the message to be consumed by their service management system, which is REDCap. In the previous Connectathon, YMCA deployed Happy FHIR server in Azure to receive eReferral FHIR message. Then, using the subscription operation, the eReferral is sent to the REDCap middleware in order to be translated to the data that REDCap can consume. Once the referral is consumed by the REDCap, the service will be provided to the patient. And once the service ends, the feedback is sent back to the provider via FHIR messaging as defined by BSeR. For the previous Connectathon, the referral flow was tested, but the feedback is left for the future task. In order to support both clinical and service providers, a generalized reference implementation architecture for BSeR has been developed. This architecture also supports YMCA architecture. To be aligned with the FHIR security and policy, Smart on FHIR is recommended for the BSeR apps. BSeR app for the clinical provider allows provider to trigger the eReferral from EHR patient chart. BSeR applications will then be communicating each other over the FHIR messaging protocol. The bottom half of the diagram shows how the proof of concept can be built using OMAP on FHIR, and how the OMAP on FHIR plays each role in the reference implementation. As data gets collected by OMAP database, all population study tools in the Odyssey community can be used for the population-level data studies and health decision support applications. Now, Tia will continue the discussion on BSeR. Back to you.
Thank you, Myung. As we conclude, I would like to touch on some of the challenges we've covered with our various partners and independently. At the top of the list is the fact that we will have non-clinical settings or community-based organizations that need to own and or work with referral information. How do we help support these organizations to do so? How do we simultaneously train them to manage and maintain any resources we provide to handle that information? What policies and laws need to be considered at each part of the adoption process? These are important questions and challenges that we keep top of mind. Although it can be tempting to try, we cannot boil the ocean. We will not be able to address every single use case as uniquely as they are in a short period of time. So we have the challenge of determining what constitutes as a bare minimum rule, and how do we scope this given various use cases that are involved in referrals. This also includes the case of closed-loop referrals and multi-directional referrals. Siloed bidirectional use cases are a challenge because they are harder to generalize. We also have the challenge of securing and maintaining non-clinical systems or tools. There are also what's called the big EHR challenge, which addresses the constraints with attempting to return information back to EHRs. And finally, one of our largest challenges is addressing workforce development as we go, which is important to have available and trained people resources to support adoption throughout. Closed-loop referrals provide a means for healthcare professionals to send patient information to a community-based organization to help address a patient's needs that are typically better served outside of the clinical workflows. A CBO can provide a variety of support programs within a community, including services that address a patient's social needs or address underlying causes of poor health outcomes with the goal of positively impacting the patient's overall health outcomes. The CBO can provide feedback on the outcome of that referral back to the referring individual or entity, as we talked about previously. But a large challenge for them is that they may not have a standardized and secure way to do so. In addition to this, many of the participating CBOs are not HIPAA-covered entities. Information that may be included in a referral might be considered protected health information in accordance with HIPAA. Some use cases make sense to leverage this information and others do not. As we make clear distinctions between the needs, we intend to work with CBOs, the CDC, and possibly the Department of Health and Human Services to provide tools to support both HIPAA-covered and non-HIPAA-covered organizations as it pertains to consent and referrals. Although CBOs generally do not have the same alignment of their incentives, for our next steps, we intend to work with CBOs to identify reasons that will motivate them to participate, including providing open insights on reducing admissions or readmissions and improving social determinants of health. We intend to work with the CDC, YUSA, referral, SMEs, and other CBOs in designing a framework for hosting and co-hosting design sessions to engage CBOs and understand their goals for our reference implementation. We want to create a platform that provides significant functionality to CBOs, which will allow them to derive more value from the platform. We also intend to address privacy, security, policy, and patient consent early in the design process. Our goal is to also train all relevant staff members about HIPAA compliance in conjunction with or prior to technology platform training. We want to ensure that staff feel comfortable with the features and functionality of the platform as well as the new workflows. Also, as part of our potential pilots, we would like to continue to educate staff frequently about the project's purpose and how it will benefit patients and clients. If you have any questions or thoughts you would like to share regarding BSeR, feel free to reach us via Whova or send us an email. We will now take your questions. Thank you.
All right, thank you. All right, so let's see, do we have any questions in the room right now?
Not at the moment.
All right, let's go online. Oh, give me 1 second here.
I do see two
All right.
questions in Whova.
Okay, yes, I see 2 questions as well. Okay, the first one says, do referrals under BSeR also transmit insurance information for the patient? Good question. Yes, the BSeR IG does have a profile definition for coverage. And I don't know if Andy or Myung, you want to elaborate on that any? Let's see here. The next question is, sorry, it kind of just hopped a little bit for me. Can you please post your slides? Yes, absolutely. We do have a PDF version of the slides that will be added to the session and provided to attendees. Okay. What cities are you, uh-oh, it just popped away. What cities are you piloting this program with the CBO? Right now, that is disclosed information or non-disclosed information, but we intend to follow up with this after we completed some pilots and share that in conjunction with the CDC as well as the YMCA. Okay. I'm not sure how to view nested questions, saying that there's replies, but I don't see how to get to them.
That's all I see in Whova for questions, but if anyone online has questions, you can unmute yourself and ask, or Nick, if you see anyone in the room that has questions, let us know. We do have 1 minute left.
Okay. Well, for those of you who have joined in person or virtually, thank you so much for your interest in also attending our session. Again, as said before, if you do have any questions in the future, you can reach us, of course, for the remainder of the conference via Whova, but we're also on Zulip, and you can also email us with the email addresses that were listed, and will also be posted to the PDF version of the slides.